Hello, I'm Melanie the midwife, and today's report on the research is on a paper called Caseload Midwifery versus Standard Maternity Care for Women at Any Risk, and it's the MANGO, a randomised controlled trial. Current high-quality evidence shows that women classified as having low-risk pregnancies benefit from continuity of midwifery care. Continuity of care is having your own midwife or midwifery team throughout your pregnancy, birth and postnatal care. The current system of maternity care in Australia doesn't offer women with risk factors the opportunity to have a midwife care for them throughout their whole pregnancy, birth and postnatal care. And in the public system, these women are often unable to access midwifery care and only have medical care with an unknown care provider, creating a circumstance of fragmented care for these women. There's plenty of research about continuity of midwifery care for low-risk women, but what's lacking is research on how well higher-risk women do under this model of care. But this MANGO trial fills the gap. So let's have a look at how the study was done. This is a randomised controlled trial, which is considered one of the highest levels of research amongst academics. The authors aimed to assess the clinical and cost outcomes of caseload midwifery for women irrespective of the risk factors, and ended up concluding that for women of any risk, caseload midwifery is safe and cost effective. Let's have a look at how they came to these conclusions. The authors included 1,748 pregnant women, 871 in the caseload program, and 877 in the standard care program at two different hospitals. And women were only excluded from the study if they'd already planned an elective caesarean, if they had more than 2 babies in their belly, or were planning to book under another care provider. Each of the women in the caseload group was allocated a midwife or team of midwives, and a senior obstetrician was allocated to each midwifery practice as well. In addition to providing care throughout pregnancy, labour, birth, the named caseload midwife attended the woman in hospital and provided postnatal care for up to 6 weeks. In the standard care group, women were just provided with the normal care that they would have been provided with at the hospital if the trial had not been going on. So standard hospital care was provided through antenatal clinics, the labour ward, the postnatal ward, where care is provided by rostered on medical and midwifery staff. And in standard care, women could potentially see a different midwife at every visit. Each group was fairly equally matched, and each contained approximately 40% low-risk women and 60% higher-risk women. Now, there are a lot of numbers we could discuss from the results, so I'll break it down. Many of the outcomes compared showed similar results for each group, so pretty much the same regardless of which group you were in, and these were the rates of instrumental births, so whether a woman had a forceps or vacuum, the condition of the baby at birth, epidural use, rates of postpartum hemorrhage between 500 and 1,000 mils, and rates of women who didn't sustain a perinatal tear. So all of these outcomes didn't seem to be affected by which type of care the woman received. Now let's look at the outcomes that differed in each group. So caesarean sections, caseload group had 21%, standard care 23%. Elective caesareans, 8% in caseload group, 11% in standard care. Unassisted vaginal births, 56% in the caseload group, 52% in standard care. Women who had no pharmacological pain relief during labour, 25% in the caseload group and 16% in the standard care group. Women who went into spontaneous labour, so either didn't have an elective caesarean or were not induced, was 42% in the caseload group and 35% in the standard care group. 24% of the caseload group were induced versus 28% in the standard care group. More women in the caseload group were augmented during labour, so 25% versus the 21% in standard care. Breastfeeding on discharge at 6 weeks and 6 months were all significantly higher in the caseload groups. If you were in a caseload group, you had 77% chance of having less than 500 mils blood loss versus 71 in the standard care group, 19% episiotomy and 22% episiotomy. First or second degree tear, 46 in the caseload group and 41% in the standard care. But in my opinion, the biggest wow in this study is that the caseload program provided care for women with no worse outcomes to the standard care group for $566.74 less per woman. That means if a hospital switched all women to caseload midwifery care, they could at least expect similar outcomes but save $566.74 per woman. If a hospital has 2,000 births, which is not that many, per year, that's an approximate saving of $1.1 million. In summary, the authors said that their findings showed no significant difference in the proportion of women who had caesarean sections between caseload and standard care of women of any risk, and caseload midwifery care seemed to cost less than standard care with similar clinical outcomes. Well, if that's not a good enough reason to restructure the way maternity care is provided and give all women a midwife, then I don't know what is. I'm Melanie the midwife, and if you found this helpful, pass it on.